Hi everyone, good evening and welcome to the Terumo Learning Edge Radial First Go Everywhere with Glidesheath Slender. My name is Jennifer Masabini and I am a Senior Education Manager here at Terumo. I'm joined here with my colleagues Ellie, Ilka, Yara, and Sydney supporting the virtual side of this recording. I have a few housekeeping items that I would like to go over. First, this presentation is intended for US physicians only. Products may not have regulatory approval in all countries, so please contact your local sales representative if you have questions about the availability of products in your area. This will be a recorded roundtable discussion, so if you have any questions regarding the topics discussed or looking for any further Terumo education opportunities, please visit us at www.terumois.com or reach out to your local sales and clinical representatives. We have a great event planned this evening, and leading the discussion will be Terumo Senior VP, Chief Medical Officer, Dr. Michael Martinelli. Dr. Martinelli is an interventional cardiologist with over 20 years in practice, and I would say probably one of the true pioneers in radial access. So with that, thank you all for joining us tonight. And Dr. Martinelli, the floor is yours. Thank you.
Thanks, Jen, and hi, everybody. And thank you for giving us your time this evening. We have a real esteemed panel to discuss something that's near and dear to our heart here at Terumo, and that's radial access. First, we'll start out by making some introductions. So why don't we go around the horn and introduce ourselves. I'm Mike Martinelli, as Jen said. I'm the Chief Medical Officer for Terumo. My experience is in interventional cardiology. And then we'll go to Dr. Peebles.
Hi, I'm Todd Peebles. I'm a neurointerventional radiologist in Wisconsin. I've been doing neurovascular procedures through the wrist for about 6 years.
Great. And Dr. Resnick is next.
Hi, I'm Dr. Neil Resnick. I'm an academic interventional radiologist in Atlanta, and I've been doing radial access for just over a decade now, 2012.
Great, welcome, thank you. And Dr. Zhiroff.
Good afternoon, I'm Katrine Zhiroff. I'm an interventional cardiologist in Los Angeles. I've been doing coronary procedures through the radial since 2012 and peripheral vascular procedures probably in the last 5 years or so.
Thank you. And last but not least, Dr. Skripochnik.
Hi, Eddie Skripochnik, vascular surgeon in New York, New York Presbyterian, Columbia. I've been doing peripheral interventions from the wrist since about 2016-ish.
Great. With regard to IR and neuro radiology, radial access seems to be, kind of a slower uptake in those fields. How do you feel that's going, and what can be done to kind of increase uptake in your areas? Dr. Resnick.
Well, I guess I would say that in IR, I think, I'll be interested to hear Dr. Peebles. I think neuro IR has been going a little slower, but in IR, I think we've been, it's been spreading out relatively quickly over the last, again, it's been about a decade since we first started, talking about it in the field. But I think all the young, kind of interventionalists coming out, for the most part, are being trained in radial, or at least if they're not being trained in their programs, they're learning it soon after. And I think most programs are teaching it. But I think the more education that can happen on a national level, even, I think the education that comes out of Terumo, for example, is very helpful in this regard. Fellows courses, those kinds of things. So yeah, I think we're interested. We're in for the most part. And I think if there are some holdouts who aren't really doing it, I think maybe those people are retiring.
Good. How about you, Todd?
Yeah, I think, probably the biggest bang for the buck is going to come from educating people from the outset. So like if you're in a training program and you're familiar with this, you're going to feel very confident going out and practicing that way. That's the best. Now, that said, I was practicing for 18 years before I started doing radial. So it's certainly something you can learn, and everybody, I think, should learn. And the more people understand what the benefit is, it's not just a cool tool to have in your toolbox. It's really primarily about, it's a dramatic improvement in patient safety.
Yeah.
I think that's the biggest thing. And so once people begin to understand that, and really take it to heart, I think that's gonna make an impact. And so, and educational things like this, and especially fellow courses, or not fellow courses even, but practicing physician courses are tremendously beneficial in giving people the confidence they need to do radial.
Yeah, I'll just build on
Yeah,
that. I couldn't agree more with that. I mean, that's there's so many procedures, as I alluded to earlier, that we couldn't do in IR with patients who are coagulopathic, who are, on anticoagulation, et cetera. Sometimes it's a very difficult anatomy that when you're trying to get a reverse curve catheter into certain vessels, it can be really challenging, if not impossible. That's how we first convinced some of the attendings that were at Mount Sinai in IR, was through some of the really challenging cases that we're able to accomplish by coming antegrade and getting into that anatomy, and being able to balloon, being able to stent, when we couldn't do that from below. So I think when people realize the benefits of it for the patient, and not just that it's a fad or something like that, but it really, it's life-saving, that's when everyone takes it up, or just about.
Yeah, I agree. Now we have literature to back that up. In the beginning, it was a little hard. It was like Todd said, it was a novel, kind of neat new thing to try after you've been in practice for, like you said, 15, 20 years. And then, as we showed the decrease in bleeding and access site complications, and then that led to a decrease in mortality, actually in the coronary, acute coronary space. I think that it's as you pointed out, Neil, it's a life-saving procedure.
And never had a retroperitoneal hematoma by going radial.
Yeah, right.
I mean, over the years, we've had to throw covered stents, had to find other ways, balloon tamponade, other ways to try to save patients from these sticks from the groin. And I think everyone's laughing because everyone's seen these. Hopefully not had them, but probably if you do enough cases, from the groin, you're going to have some complications. And when you're at the wrist, it's so superficial, right? And you can just hold pressure if you need to. And if you do thrombose it, it's not the best, but at least it's not life-threatening.
Right. That Friday night, 2 a.m. phone call from the last case doesn't happen anymore, right?
Yeah,
for that reason anyway.
And I think we've been in vascular surgery, we've also been very slow to pick this up, but I think anyone who gets involved with a patient with multiple, let's say, open operations in the groins, or even multiple sticks in the groins in the past, different bypasses, severely obese, groin infections. Once you touch one of those patients and you have this option in your back pocket, and you start to value it, and then it goes from the back pocket into the front pocket, right? So it's much more easily accessible, and you start to grow. So I think that's the way that we've converted so many vascular surgeons.
Yeah.
And I wish we can target more in training.
Yeah, that's a great point. Yeah, where I came from, our vascular surgeons were not, very resistant to it in the beginning. And then once they started, they came over, we all did it together, and they just took off. So it's, once you become familiar with it, as you said, once you do enough, once you become familiar with it, familiar with the ultrasound and how to do best practices, it takes off. And most importantly, I mean, we haven't really mentioned this yet, but patient satisfaction is, off the charts. I mean, they would begin to ask for it, as you all probably know. And you can't beat that. So, well,
I'm so sorry. I was gonna say, we definitely saw that in the IR world, and that's kind of one of the first things that really pushed us to get this going. Because when we'd have those TACE patients, there was that early study out of Japan, where they really showed that these patients would ask for, if they've had radial and they had femoral, and they would say, "Can I please have radial next time?"
Yes.
And we've definitely seen this in our experience.
Great. Well, thanks so much, everyone, for all your time and your expertise. We really appreciate it. I think that these types of discussions are really beneficial for our audience, and we're certainly grateful to have real champions like yourselves. So thank you very much, and we really appreciate all the time you spent.